We have the privilege of inviting Dr. Chee-Soon Phaik. She's a dear friend, and she's almost like one of our AIOS members. Over the last year that we've had webinars, I think she's attended not less than 20 of them. So our Indian audience would be very familiar with her. She's equally good with uveitis, with crazy dangling cataracts. So she's going to be speaking on overcome by capsular
Hello, everyone.
fibrosis.
First of all, okay, sorry that started prematurely. So I pre-recorded this so that I'll stay on time. Hello, everyone. First of all, I'd like to thank Ashwin and Gaurav for inviting me to participate, and I'll be speaking on overcome by capsular fibrosis. These are my financial disclosures with no relevance to my talk today. Anterior capsule contracture syndrome is caused by centripetal fibrosis and contraction of the capsulorhexis. It is more common when the capsulorhexis is small and the zonules are weak. It occurs especially in eyes with pseudoexfoliation, uveitis, and retinitis pigmentosa. The patient should be managed when symptomatic, and in mild cases, a YAG anterior capsulotomy can be done. For moderate cases, a femto or manual capsulotomy. How about the severe cases where the intraocular lens is decentered or tilted? This first case is a 26-year-old female with a past history of uveitis currently off treatment. She underwent uneventful left phacoemulsification with intraocular lens and goniosynuclear lysis for glaucoma, and she was referred at 3 months post-operatively when her vision dropped to 6/21. You can see on slit lamp photo that she has got severe capsular phimosis, and the UBM showed that the IOL was tilted. At the time of surgery, you can see a really small opening in the capsule, and we inject that with dispersive viscoelastic to distend the capsular bag, and then grasping the anterior capsule with non-tooth microforceps and the fibrosis beneath with tooth forceps. We then gradually tease the scar tissue away from the anterior capsule, and you can see that what I do is not just tease it outwards but also downwards, and this makes the dissection much easier than if we were to just try to pull it forwards. And we have to switch hands as we move around, but we're able to do this relatively completely 360 degrees around. Once we've removed the fibrosis, you can see the capsule opening has enlarged now, and the folds are no longer so tense. After injecting enough dispersive viscoelastic, we inject a capsular tension ring. You need to be very careful there in case you have any resistance that you do not push, in case you rupture the bag. The next important step is to enlarge the capsulorhexis, which is easily done because the fibrosis is removed, except for this area here. When I encounter fibrosis, I'm providing the counterforce as I complete the enlargement of the capsule opening. At this stage here, we have a reasonably centered IOL, and we can even go behind the IOL to remove dispersive viscoelastic safely. And importantly, at the end, I inject intracameral dexamethasone that's preservative-free to ensure she does not have post-op inflammation. At post-op month 1, you can see she has got 6/12 vision restored, and her posterior capsule is reasonably clear, although some striae are still seen. This is a second case where a 71-year-old female underwent left phacoemulsification with trifocal toric intraocular lens and had persistent post-operative inflammation. She was referred for a decentered IOL 3 months post-operatively, and her vision had dropped to 6/18 and 10, and she also had mild cystoid macular edema. You can see again the severe capsular phimosis, and the UVM showed that the IOL was tilted and decentered, and the zonules were also dehisced in some areas. At the time of surgery, you can see that this capsule is really phimotic, and in addition, the lens is rather unstable. We use hooks to support the lens, and we see vitreous presenting where the zonules are deficient. We stain with 50% diluted triamcinolone acetonide and do dissociated vitrectomy to clear the vitreous, and then we support the rest of the capsular bag as we begin to tease the fibrosis tissue from the anterior capsule, which we're holding gingerly with non-tooth forceps, and the scar tissue with capsulorhexis forceps. And we switch hands when we move around, and we do this very patiently as we go around 360 degrees. And you can see we're making progress here. And you can see the haptic being buckled forward by the severe fibrosis, and areas where we cannot make progress, we then cut the fibrosis to release it, and we use more dispersive viscoelastic to separate the anterior from posterior capsules that are held by adhesion. And then this area here, you can see severe fibrosis that extends from the anterior to posterior capsule, and that's where I stop. And I would rather truncate this fibrosis because you do not want to compromise the posterior capsule. And as we move around, again, we remove all this fibrosis. You can see an area here that I've actually ripped the anterior capsule appearing now. And because of that, I'm able to use a capsule tension ring. In this case, I'm going to use 2 capsule tension segments to support the capsular bag in order to spare this multifocal toric lens. I insert the CTS that is being preloaded with Cortex 7O, and after creating Hoffman pockets and marking 1.75 mm posterior to the limbus, I use a suture snare which I've created with 26 gauge needle to extend a loop of the suture to lasso the end of the suture to the fixation point through the Hoffman pocket. And this is done easily on this side here, but for the opposite side, you're going to see me do this very, very carefully. And you can see that the rip is present here, and I'm just going to be so careful so that I don't extend that rip as I insert the capsule tension segment, and repeat the procedure that you saw. And now I'm retrieving the sutures from the Hoffman pocket, and then we do a 2-1-1 knot. So after the 2 throws, we gently adjust the sutures to support the lens and ensure it is centered before we finalize it with 2 more throws. And then the knot is placed in the Hoffman pocket. So this patient 1 month post-operatively was able to see 6.5 and 5. And you can see that on UBM, the lens has been restored to anatomical position and is well centered. So in conclusion, severe cases of capsular phimosis require surgical management. Peeling of the scar tissue from under the anterior capsule can be achieved. A small CCC should be enlarged, and a CTR should be inserted where possible. Intracameral dexamethasone and control of postoperative inflammation are important, and IOL centration and stability can then be restored. Thank you very much.
That was remarkable, Dr. Chee. It was just so brilliant. You have to kind of hold your breath and keep watching.